Good evening, everyone, and welcome to this last webinar of EURETINA for 2025, which will be dedicated to Uveitis Dilemmas for Retina Specialists. My name is Bahram Bodaghi. I'm an ophthalmologist in Paris, France, and it's my pleasure to chair this session, this webinar with my friend, Professor Carlos Pavesio from Moorfields in London, UK. And we have a great panel with us with a lot of topics which are to us important for retina specialists and of course for uveitis specialists. So we wanted to share all this program with you, and we will probably have some times for questions. You can use the chat, and if not, at the end we will have some time for the Q&A. With this, I will give the podium to Carlos. Carlos, please.
Thank you, Baran, and good evening to all of you. And it's nice to see so many people connecting for our last webinar of the year. So without further ado, and not to delay further the presentations, I'd like to introduce Aniruddha Agrawal, a friend and a very great colleague, to discuss differential diagnosis of occlusive retinal vasculitis. So Aniruddha is based in Abu Dhabi, the Cleveland Clinic, and he does, apart from uveitis, also VR and MR work. So Ani, over to you.
Hello, and thank you very much to EURETINA. Thank you, Professor Pavesio and Professor Bodaghi, for this opportunity. And so I'll kickstart by talking about some differential diagnosis of occlusive retinal vasculitis. And the reason why this is so important to all of us is that a lot of times patients with retinal vasculitis, specifically the occlusive vasculitis, may present to the retina specialist, and the diagnosis of ocular inflammation may be quite delayed. We must understand that retinal vasculitis is a sight-threatening manifestation, and it has systemic associations in several patients. There is a subset of patients where the occlusion of blood flow can happen, and these patients require prompt treatment, early intervention, so that you can prevent complications, structural complications to the retina, and you can have better prognosis in these patients. In general, how do we define occlusive retinal vasculitis? It's simply an absence of blood flow through arterioles or venules and or capillaries. So we like to classify if it's arteriolar or venular involvement. And you can identify most of these cases clinically, and you can confirm using fluorescein angiography. But often you may not see capillary non-perfusion clinically, and you need fluorescein angiography to look at capillary non-perfusion. And oftentimes, aspects such as arteriolar venous anastomosis may be more prominent on fluorescein angiography. Now, there could be sometimes very subtle signs of occlusion, just intraretinal hemorrhages or cotton wool spots, without any obvious large vessel occlusion, or you may simply have vitreous hemorrhage. So when you have this, you can also assume that there is an occlusive retinal vasculitis. And as you see in the table, there are a number of causes, both infectious and non-infectious causes of occlusive vasculitis, ranging from TB, SLE, multiple sclerosis. Some viruses can cause occlusive vasculitis. Of course, we have Behçet's disease, Susak's, syphilis, and some of the other connective tissue diseases. So in general, you have several review articles and manuscripts that have been published in terms of occlusive retinal vasculitis, and I'm putting out some of these for your further reading. But if you think about, if you have a patient of retinal vasculitis where you think that there is an occlusion, what I would suggest you to do is differentiate first and rule out TB. And I'll show you some cases where TB can be quite straightforward disease. It can be ruled out in several cases, especially if the patient is coming from an endemic country. And once you've ruled out TB, which is really a large chunk of the disease, then you're left with autoimmune and viral causes of occlusive vasculitis. Now, among the viral and autoimmune, sometimes it's very difficult to differentiate if it's an infection or it's just an autoimmune etiology. And in those cases, to differentiate, you may have to rely on serology or PCR, certain labs to understand if this is really an infectious disease or it's a manifestation of an infection, or not just viral, but even other rare causes like syphilis or certain bacteria or other organisms. So in general, if there are large series have been published, and this is a particular series that we published screening more than 2,000 patients, and we realized that most patients of occlusive retinal vasculitis, they are young patients. They're in their 30s, 40s, in the middle age group, and most of them are males. So there is a heavy association with male gender. And because TB is a predominant cause of occlusive vasculitis, you'll see a lot of Asian Indian population there because the disease is obviously endemic in that country. But also you have several countries where TB is an emerging disease or it's a problem or a public health burden. In general, if you look at the arteriolar involvement or venous involvement, you have patients with predominantly arteriolar or venular or even combined involvement of the disease. And in general, you see that venular involvement forms a chunk of patients. Patients with arteriolar disease are very specific and much fewer than venular involvement. And many patients can have peripheral retinal involvement or extensive involvement, involving more than two quadrants more, and they are very much predisposed to developing neovascularization and other complications, other retinal complications like tractional retinal detachments and vitreous hemorrhages. So moving forward, as I said, TB in the Asian Indian population forms a large cohort of patients. Previously, we used to refer this as Eels disease, but really now, after the collaborative ocular TB study has been published, we prefer to call it tubercular retinal vasculitis instead. And this is again like a major bulk of the disease. Behçet's disease is another important entity which causes occlusive vasculitis, and of course, certain viruses, Lyme's disease, syphilis, and SLE, these are other causes of occlusive vasculitis. So in patients where you have perivascular choroiditis and capillary non-perfusion, and the patient comes from an endemic country, originates from an endemic country by race, not by immigration, in those patients, you can be very highly correct if you say that this patient has tuberculosis. Your positive predictive value is quite high, and so also your negative predictive value. And to the constellation of perivascular choroiditis, if you add retinal neovascularization and vitreous hemorrhage in a patient from endemic country, you're almost always correct if you label the patient as tubercular in etiology. And various studies have shown that analysis or PCR testing in these patients can reveal TB bacilli or the proteins in the vitreous humor, or even the aqueous humor. There are studies to show you the presence of the DNA, mycobacterial DNA. So this is the classic presentation, and really, if you look at this patient, sometimes the detection of vascular sheathing or obvious retinal vasculitis clinically and even on fluorescein is very difficult. Sometimes you have only such kind of retinal hemorrhages, and at this time when you're seeing the patient, most likely the disease is really burnt out, and what you're left with is the complications such as neovascularization and bleeding. But on the other hand, sometimes you have patients who present with the full spectrum, where you have a frosted branch angiitis like appearance, and you have pre-retinal hemorrhages, extensive neovascularization, even though you may not have that much of non-perfusion. And these are patients with distinct perivascular choroiditis lesions or distinct perivascular sheathing, which is very exuberant in these patients. So, close look at the periphery to detect perivascular choroiditis is very important. As you see here, this case example shows you very elegantly the presence of perivascular choroiditis lesions. Um, Sometimes you may have even serpiginous like lesions associated with occlusive retinal vasculitis in patients with TB. Moving forward, if you look at the differentiation of TB, previously called EELS and non-TB, you have a lot of changes that are very specific for TB, like AV anastomosis or neovascularization with perivascular choroiditis, or a combination of these findings. So when you have a combination specifically, please think of TB, and I would suggest to do all investigations to rule out tubercular etiology. This is another patient showing you severe vision loss, submacular hemorrhage. So just to show you the spectrum where you have submacular hemorrhage, arteriovenous anastomosis, and scars in the choroiditis lesions, there perivascular and occluded vessels, This is the other eye of the patient, partly treated with laser, and you see the occluded vessels and choroiditis scars as well. And so this is a classic fluorescein angiography appearance where you have non-perfusion, arteriovenous shunting may also be there, and these patients may develop neovascularization. Moving forward, if you look at the OCT angiography, not only TB but even other etiologies, you will see sometimes the perfusion is definitely compromised, not only in the center but even in the periphery. Behçet's disease can present with vascular occlusion. So this patient has not only retinitis lesions, but Behçet's can present with capillary non-perfusion. And this is very important to understand. Behçet's is an important differential diagnosis, and lupus often presents to the retina specialist with significant amount of capillary non-perfusion, almost a total wipeout. So this could be even a drug-induced lupus or a systemic lupus erythematosus, and these patients require extensive laser, and sometimes despite laser the leakage can continue, and these patients require combination therapies to control the neovascularization. Suzak syndrome again can present to retina specialists with recurrent BRAO, branch retinal arterial occlusions, and the vasculitis may be really very focal, and fluorescein angiography may be the only option to detect these retinal vasculitis. I just want to talk to you about CMV as well. And CMV retinitis, can present with occlusive disease. This is a patient with a severe vision loss and headache, and was diagnosed as central retinal vein occlusion. Young female, and so was investigated for various systemic or metabolic diseases. But if you look at the patient profile, an MRI was done, AC paracentesis was done for this patient, and viruses were detected, CMV. And Dr. Bodaghi has described this non-necrotizing herpetic retinopathies. And since then, there are several cases of cytomegalovirus occlusive vasculitis that have been published. So I'm just ending here in half a minute. So the complications of occlusive disease include CME, which is hemorrhages, again tractional detachments, and often they require surgery and anti-VEGF injections. But one very important aspect of the treatment for these patients is going to be systemic immunosuppression. So these patients often require biological therapy or systemic immunosuppression. I'm going to skip again this case of TB, but to show you, don't forget please, anti-VEGF associated occlusive retinal vasculitis is an important entity that must be considered in patients undergoing treatment, especially some of the newer anti-VEGF agents. They can present with occlusive retinal vasculitis. So with this, just to conclude that retinal vascular occlusion can be seen in 20% or even more patients of retinal vasculitis, and high rates of complications can be observed. And so it's important to consider all differential diagnosis and initiate prompt treatment. Thank you very much. Thank you.
Thank you. Thank you, Annie. It was a great presentation with a lot of great pictures. I had one question for you
Yes.
because we are, of course, we have a lot of retina colleagues who are connected. Uh, it's important to maybe differentiate vasculitis and vasculopathy. So can you
Yes.
just in a few seconds tell us about this entity?
So retinal vasculitis really is an inflammatory disease involving the retinal vessels, whereas vasculopathy essentially means that there is a compromise in the blood-retinal barrier. And that can happen from various conditions such as non-inflammatory conditions, even such as venous stasis, or sometimes even SLE, where the mechanism is not an inflammatory mechanism, but it's just a breakdown of the barrier. So these patients can present with venous stasis-like disease, or they can present with secondary complications mimicking CRVO and neovascularization, but essentially they don't have inflammation and they don't need anti-inflammatory therapy.
Thank you. I think this was a very important comment. Thank you very much. And with this, it's
Thank you.
my pleasure to introduce our friend and colleague, Professor Elisabetta Miserocchi from Milano, Italy. And Elisabetta, one thing which is really scaring to all of us is this acute inflammatory subretinal detachment. So please let us know about the diagnostic and therapeutic management in 10 minutes.
Thank you, Bahram. Yeah, I'm gonna treat these challenging topics, which is the acute subretinal detachment, which can present a sort of important dilemma, because when you have a patient in your clinic and you see such a detachment, sometimes you can have many doubts, and you don't know if you have to call the vitreoretinal surgeon, the retina specialist, or the uveitis specialist. So I'm gonna try to help you in the differential diagnosis, because sometimes the subretinal fluids may be so important that you can see large pockets of subretinal fluids and inflammation. So basically, in general, you can have a similar clinical picture for different diagnosis and condition, and in most instances the diagnosis should be clinical, but sometimes you can get help from serology and cytopathology and clinical history. But you can see in those pictures you have color fundus photos and OCT that are pretty much very similar in VKH, sympathetic ophthalmia, and choroidal lymphoma. So I tried to divide the different diseases that can present with acute subretinal detachment in inflammatory, non-inflammatory, neoplastic. And I have to tell you that imaging is probably the most important factor that help you in differentiating this disease, but you can also get a correct diagnosis through a correct history, serology, and pathology in your patient. So this is the agenda and of my presentation. I'm going to start with the inflammatory condition, and Dr. Yanagi-Arada, VKH, is probably the queen of the acute subretinal detachment, and I'm going to show you some clinical cases. This is the first one of a young female presenting with acute visual loss, and she presents with white spots in the retina and bilateral neurosensory retinal detachment. You can see on the autofluorescence the presence of hyper autofluorescence around the optic disc. And on the OCT, you can appreciate obviously the neurosensory detachment, also a very thick choroid with the featureless appearance, which is typical from VKH. And on fluorescent angiography, this patient may present with optic disc hyperfluorescence compatible with papillitis. And if you have an ultra-wide field optos, you can see that this patient also presented with some peripheral neurosensory detachment in addition to the posterior pole detachment. So the key imaging tool is ICG, because through ICG you can see that this is a patient that has a stromal choroiditis, and you can see the diffuse hypofluorescent spots, which are compatible with stromal choroiditis and with the diagnosis of VKH. Here is another one, a young lady who presented with, again, bilateral visual loss. You can see that she has optic disc edema and the blonde macular reflex. This patient also presented with those large pockets of subretinal fluids in the inferior part of the retina and also at the posterior pole. And more interestingly, if you look at the FA of this patient, you can appreciate again papillitis with the hot disc, macular hypofluorescence, and on the OCT you can see that this patient had a very large neurosensory macular detachment, which was visible as a bacillary detachment. So you can see these large pockets under the macula, and again a featureless choroid and choroidal folds. Here's another one, lady from Peru, and you can see that the VKH in this patient appeared with these large pockets of dye pooling on FA, and on the OCT you can see again the neurosensory detachment and the featureless choroid. So there are other conditions in which you can see VKH appearance, and this is a VKH like uveitis in patients who has cancer and is taking immunotherapy. And we are seeing more and more frequently patients with VKH like uveitis induced by those target cancer therapies. So, but basically the clinical presentation is exactly the same to other patients with VKH autoimmune disease. So there are other signs that can help you in the diagnosis. The presence, for example, of an anterior granulomatous uveitis. But basically, to diagnose a VKH, you need, of course, typical ocular features of granulomatous panuveitis, stromal choroiditis, as you have seen in the ICG, and acute neurosensory detachment. And some patient may also present with systemic features compatible with the skin manifestation like vitiligo and poliosis, ENT and CNS manifestation. And for the treatment, you have to remember that these patients should be treated very aggressively with high dose IV steroids or oral steroids, and then they should rapidly be treated with aggressive immunomodulatory therapy. So the second inflammatory disease that should be put in the differential diagnosis with VKH is posterior scleritis. So basically, the fundus appearance is identical to VKH. This is a, a woman with acute unilateral visual loss with mild pain, and you can see that the FA and the OCT are exactly identical to a VKH patient. Here is another one. And you can appreciate the retinal folds, the choroidal folds, the thickening of the choroid, and the featureless choroid, which are compatible with posterior scleritis. Sometimes, if you are lucky, you can see a T sign, which is typical for making a diagnosis of posterior scleritis. But there are conditions in which there is a lack of pain symptoms. So in those cases, it's more difficult to differentiate between VKH and posterior scleritis. But basically, the treatment should be the same with high dose oral corticosteroids and then immunomodulatory therapy. But if you're suspecting a posterior scleritis, of course, you have to rule out autoimmune systemic disease or infectious disease or vascular disease, and then you should treat your patient with the IV oral steroids and chronic immunomodulatory therapy. So the second group of disease, your non-inflammatory disease, and central serous chororetinopathy is one of the most important diseases to rule out and differentiate from other type of inflammatory disease. There are classical picture of central serous, but there are other that can mimic VKH, and actually those are the bullous variant of central serous. This is a patient who was misdiagnosed as VKH, treated with high dose steroids, and then, but in fact, this was a central serous, and she had this huge subretinal detachment. But of course, OCT and FA may help you in making the correct diagnosis of central serous. And the last group of disease are neoplastic disease that can present with subretinal, acute subretinal detachment. This is the case of choroidal lymphoma. You can see the choroidal folds, the subretinal fluids. On FA, you can have unspecific signs of leakage and hot disc. But basically, for making the correct diagnosis, you need to biopsy the chororetina and make a correct diagnosis of choroidal lymphoma. Another type of neoplastic disease that can present with subretinal detachment is choroidal melanoma. And this lady, actually, we took many months to make the correct diagnosis, because at the beginning we were thinking about choroidal lymphoma, but then after 2 biopsies, we ended up with the diagnosis of flat amelanotic choroidal melanoma, which is a very rare entity. And my last picture is about choroidal metastasis that can also present with subretinal detachment and subretinal fluid associated with the choroidal mass. I thank you for your attention.
Thank you, Elisabetta. That's a very challenging topic, and you pointed out a few important differentials there, especially I think CSR and the range of the pachychoroid ones. So sometimes uveal fusion is also an important one, because this choroid is very thick and leads on to a lot of retinal problems. I think the other thing I want to mention is some paraneoplastic conditions like B-dump can produce quite good serous detachments as well. So it's another one important to remember in the range of these malignancies. The issue about the VKH, Elisabetta, I was just thinking there when you put our criteria there, but some of those are typical of the acute phase, but you also mentioned some systemic which are not exactly present in the very early stages. So I think it's probably, if you want to elaborate on that, because I think it's important for the non-uveitis person to, sometimes people are looking for the poliosis, looking for the vitiligo in the acute presentation, and that's not going to be there in the acute phase. It's going to happen a bit later on, so they cannot rely on that for the diagnosis. Just if you want to elaborate a bit on that.
Yeah, thank you, Carlos. Actually, in our experience of VKH in our Italian referral center, I would say that the majority of the patient, they will never develop systemic symptoms, and they only have the subretinal detachment, the stromal choroiditis, but then they will not reach the stage, or maybe because of early institution of immunosuppressive therapy and high dose steroids, they will never develop systemic. I think it's probably also a matter of ethnicity, but we have a lot of South American patients immigrated in Italy that they present only with the ocular part of the syndrome, and they don't have the classical VKH complete syndrome. So I don't know in your experience, but in our experience, most of the patients, they have all the ocular part.
Yeah, I think it depends also how aggressive you are when you're managing the acute presentation. So if you control it very rapidly and very aggressively, then the other manifestations may not occur because you aborted it. So yeah, I think it's a combination of factors. But but thank you, Elisabetta. Really, really great presentation on a difficult topic. I'd like to introduce our friend Zohar Habot-Wilner, who will present on how to diagnose infectious uveitis. So Zohar, over to you.
Thank you so
Zohar
much.
is based in Tel Aviv, and we'll talk on this also very interesting topic. Thank you, Zohar.
Thank you so much, Carlos and Bahram, for this wonderful webinar. So my presentation is on how to diagnose infectious uveitis. The prevalence of infectious uveitis exhibits significant variations, and this is influenced by the geographic location of the patient, the environmental conditions, the socioeconomic status, and genetic predispositions. The prevalence is higher in South America, Africa, and specific locations in Asia, including Pakistan, India, and China, while it is much lower in the USA and Europe. In this lovely table, we can see the most common infectious uveitis causing agents by geographic region. We can see that toxoplasmosis is mostly common in Africa, Central and South America, and also may be seen in Europe, while herpetic eye disease is mostly seen in North America and also in Africa and Europe, CMV anterior uveitis mainly in Europe, and TB in Asia and Africa, while syphilis is mostly seen in Africa, but we all know that the cases are increasing all over the world. It is crucial to diagnose the infection, as delayed diagnosis can cause irreversible vision loss. In addition, the use of corticosteroids or other immunomodulators can worsen the infection. And moreover, the diagnosis itself enables the prompt initiation of appropriate treatment, which is essential for controlling the infection. We should use a systematic diagnostic approach, and this includes taking a thorough medical history and review of systems, comprehensive ocular examination, and using ocular imaging tests, and then we need to correlate the systemic and ocular findings in order to generate a good differential diagnosis. The next step will be to order targeted diagnostic tests. It is very important to have a good medical history, as this helps us to understand who is the patient in front of us. The age is important, as different infections may appear differently in different age groups, as well as among women or men. The geographic location, the occupation, travel history for endemic areas, tick or mosquito bites, and exposure to animals. The sexual history is important as well. The systemic diseases, past infectious diseases, past hospitalization and surgery, any recent illnesses, the medications that are being used, social habits, past ocular history, and also family history for infectious disease. It is crucial to conduct a comprehensive patient interview with a thorough systems review. We should be familiar with the diagnostic clues of ocular infection, as various infections may affect different parts of the eye, as is nicely seen in this table. It is important to recognize the different clinical patterns. We need to understand if the patient has retinitis or choroiditis, if it is focal or diffuse, if there are other parts in the eye that are involved in the inflammatory process, if there is vasculitis, if there is retinochoroiditis, in which the inflammation and the infections comes from the retina into the choroid, as is seen in toxoplasmosis, or is it chorioretinitis, as is seen in syphilis and fungal infections. We need to recognize the ocular imaging patterns and to always try to use the multimodal imaging tests. And I'll start with the examples. This is an example of focal retinitis, which is seen in toxoplasmosis. And with active lesions, we see deposits on the hyaloid and retinal surface. We can see that both the retina and choroid are thick and disturbed. And with the healing process, we can see that the deposits are gone and the retina choroid became thin due to the necrotic process. So how should we diagnose toxoplasmosis? This may be very easy and simple if we see the characteristic clinical findings, which are the presence of a chorioretinal scar with an adjacent retinal lesion. In such a case, we don't need any lab tests and the diagnosis is very easy. But if we don't have a scar and there is only a focal or paucifocal necrotizing retinitis, we need to prove the infection by positive serum IgM antibodies against toxoplasmosis or positive PCR, or if we use nowadays the metagenomic next generation sequencing test. And now I'll go to diffuse retinitis. This may be seen with various infections, including toxoplasmosis, mainly in immunosuppressed patients, acute retinal necrosis, CMV retinitis, syphilis, and even in a masquerade syndrome such as vitreoretinal lymphoma. Syphilis may be seen with any type of uveitis. In posterior uveitis, we can see necrotizing or multifocal retinitis, and also chororetinitis that has two types. The confluent type, in which we see the lesions as a ground glass appearance, sometimes with superficial preretinal precipitates, which are nicely seen in the OCT. The second type is acute posterior placoid chororetinitis, which is a placoid yellowish outer retinal lesion involving mainly the macula. And the OCT is very important to understand and realize the disturbance and the irregularities of the outer retinal layers. And with the healing process, in most of the cases, we can see complete restoration of the outer retinal layers. And this is a very nice example showing the importance of using the multimodal imaging tests. With the use of the fundus autofluorescence, we can depict much more lesions that can be seen with the clinical examination. And with the use of the fluorescein angiogram, we can appreciate the appearance of the optic nerve head and the retinal vessels as well. How should we diagnose syphilis? This should be done by blood test, screening with a treponema test for syphilis IgG or FTA. And if these are negative, so there is no disease. But if these are positive, we need to go to a non-treponemal test, which may be the RPR or VDRL. If these are negative, we need to have a treponemal test, the TPPA. And if this is negative, so there is no disease. But if this is positive, so we have the diagnosis. Another disease that may cause necrotizing retinitis is acute retinal necrosis, which is caused by VZV or HSV. But in this disease, we need to see also retinal vasculitis and vitreitis. The diagnosis is done by a positive PCR or NGS from ocular fluids. And once again, it is very important to have the OCT done as it shows us the necrotic area. But in contrast to toxoplasmosis, here there is no involvement of the choroid. CMV retinitis may be seen with three different types. The fulminant hemorrhagic type, which involves the posterior pole with retinal necrosis and edema. The granular type, which involves the periphery with no necrosis and hemorrhage. And the perivascular type with the frosted bunch uveitis. Once again, very important to use the OCT, and the diagnosis is done by a positive PCR or NGS. And now I'll go to choroiditis, which may be seen, of course, with TB, and we need to differentiate between serpiginous-like TB and classic serpiginous. In TB, the disease is mostly unilateral. We may see involvement of other parts of the eye. The lesions began in the posterior pole, they are multifocal, and we may see pigment clumping at the center of healed lesions. The OCT is also a very important tool in cases of choroidal tuberculoma for follow-up after the patients, and also it may help us to distinguish between sarcoid granuloma to choroidal tuberculoma, as in TB we may see involvement of the outer retinal layers. And here are two other examples of TB, subretinal abscess and retinal vasculitis, and I thank my very good friend, Professor Aniruddha Agrawal, for these lovely pictures. It is quite tricky to diagnose the ocular TB, and to confirm the diagnosis, we need to have a microbiological confirmation of the infection from ocular fluids by a positive PCR, positive culture, or positive NGS. So in many cases, we can say that there is a probable disease if there is a compatible chest X-ray or clinical evidence of extraocular disease or microbiological confirmation from sputum or extraocular sites in a patient with documented exposure to TB or positive TST or positive IGRA test. And finally, neuroretinitis, which is another type of posterior uveitis. This may be caused by non-infectious and infectious diseases, and this is a very nice picture of cat scratch disease with the classical inflammatory angiomatous optic nerve lesion. And last but not least, we need to be familiar with the different serology tests for infectious uveitis, as although the disease is in the eye, the diagnosis of many diseases are done by blood testing. So in summary, the diagnosis of infectious uveitis may be challenging. We need to have a thorough medical history and review of systems to recognize the clinical and ocular imaging patterns, and then to have targeted testing, which are essential for establishing the correct diagnosis. Thank you very much for your listening.
Thank you very much, Zohar. Just one quick question because we need to move on, but how often you are going for intraocular fluid sampling? For example, AC tap.
So AC tap, I'm doing actually quite a lot if I'm not sure, according to the clinical findings, what may be the diagnosis. And I find it very helpful, mainly using the PCR technique. And nowadays, I also have the NGS test. So if I am not sure, and I think that this is a very tricky condition, I may use it. And I find it quite helpful.
I think NGS is probably the future if the prices are going down, but it's coming. Thank you, Zohar. And with this, we move on to a topic which is, of course, very important to all of us, and this is macular edema. And who better than Dr. Ilaria Testi, who is working also in Moorfields in London with Professor Pavesio, to maybe explain how we can choose between local versus systemic therapy. Thank you, Ilaria.
Thank you. So I would like to start my presentation by showing you these two OCT scans. So same macular edema morphology, same intraretinal cyst pattern. So should these two patients be treated in the same way? Of course, the answer is no, because context dictates the treatment. So let's focus now on case number one. So 54-year-old male, right eye, blurry vision and floaters for 2 months, diabetes, systemic hypertension, and high cholesterol. So we focus on the right eye, vision down to 636. You have some vitritis, vitreous debris, you have macular edema. And when you perform your FFA, you see that there is mainly a retinal vasculitis with vascular leakage in the right eye. Left eye, only some mild peripheral vascular leakage. All bloods and investigation came back negative. So we have a non-infective posterior uveitis, or intermediate, as you want to call it, with no systemic involvement, bilateral but asymmetrical in a patient with systemic comorbidity. So of course, in this case, our preferred choice was dexamethasone implant, so local treatment. So we put the DEXA implant after 2 months, beautiful resolution of the vitritis and of the CMO, but of course we have a limited duration of effect. So after 4 months, we have a recurrence of retinal vasculitis and CMO. So we decided to go with another DEXA implant followed by a fluocinolone implant with the beautiful control of the disease after 1 year. The second case with the same CMO was a 52-year-old female, both eye, blurry vision, and floaters for more than 1 year, systemically well. And when you take a look at the other eye, you see that there was something going on, epiretinal membrane, some mild cyst. And then you take a look at the broader context, and here we go. So you have the typical depigmented lesion that you see in birdshot. We have active stromal choroiditis on the ICG. We have diffuse leakage on the FFA. So in this case, your treatment will be systemic. So we have a non-infectious posterior uveitis without systemic involvement, is bilateral, but you know by the natural history of the disease that is chronic. So you will need not only oral steroid, but you will also need systemic immune suppression. So why sometimes we get CMO treatment wrong? So what we don't see on the OCT scan. So first of all, sometimes we just treat the picture instead of the patient. Sometimes we can miss the systemic disease, and also we focus on the retina only and we forgot the choroid. So remember, the macular edema is an expression, is a manifestation, is not a diagnosis. So I prepare for you this flow chart on the therapeutic approach of uveitic macular edema. So if there is intraocular inflammation only and is unilateral or bilateral but asymmetric, local therapy makes sense. But if the disease is bilateral symmetric, or of course you have a systemic disease, then you will have to go with systemic treatment. But of course, it's not so easy because there are other parameters that you have to keep into consideration. Uveitis entity, location, and of course, contraindication to systemic treatment or local treatment. So what are the general indications for systemic treatment? We have seen bilateral disease, systemic involvement. Pay attention to this. If you have choroidal involvement, and we will see later, you will need to go with systemic treatment. And then, of course, when you have contraindication to local treatment, like children, young adults, glaucoma, high IOP, or anatomical factors, for example, a phakic or anterior chamber lens. Systemic treatment, stepwise approach treatment. You start with systemic steroid. I'm not going into this because we have no time. If you're not managing to taper down and stop the steroid without having recurrence of inflammation or in severe disease or in chronic disease, you might need to escalate to systemic immunosuppression. But I just want to focus your attention on biologic and in particular on interleukin-6 inhibitors, TOC, tocilizumab, because there is substantial clinical evidence for refractory uveitic CMO. So they just published this systematic review and meta-analysis 2 months ago on the effectiveness of TOC in refractory non-infectious uveitis. And look at this result. Macular edema resolution pool rate was 93%. So TOC is really useful if your main problem is recurrent macular edema. And what about local treatment? So I decided to focus on local implants. So we have the DEXA implant. Remember that is licensed for active disease. And then we have the fluocinolone implant that is licensed for prevention of disease relapses. So what are the general indications for local treatment? So no systemic involvement, unilateral disease or bilateral but asymmetric. We will see very soon what happens if you have choroidal involvement. And then, of course, you need to go with the local treatment when you have systemic contraindication or intolerance to systemic treatment, or also resistance to systemic therapy. But remember that also a combined approach with systemic treatment can be very useful if you have to reduce the systemic burden or as a bridge while systemic immunosuppression takes effect. And I prepare for you this case. So 45-year-old birdshot retinochoroiditis, active vasculitis, active choroiditis, bilateral CMO. So of course you need to go with systemic treatment. We start prednisolone, tapering down to 5. We start MMF. But you see that we still have an active vasculitis with active CMO in one only eye. So at this point, patient was not very keen to increase systemic immunosuppression. So we have decided to put a DEXA followed by a fluocinolone implant. And you see we have a beautiful resolution of the vasculitis and the CMO without increasing the systemic treatment. And what about choroid? So remember that fluocinolone implant is really useful in CMO and retinal vasculitis, but is not working in choroidal inflammation. So if you have deep choroidal inflammation and CMO, local treatment with fluocinolone is not your preferred choice. However, DEXA work quite well in stromal choroiditis, and you can see here an example in birdshot. The problem is that, of course, is a limited time of effectiveness. So after 3-4 months, of course, you will have to put another implant. So in chronic disease is not really great. So far we have focused on CMO in intermediate, posterior, or pan-uveitis, but what happened in CMO that you have in anterior uveitis or post-op CMO? So I prepare for you very quickly this flow chart. First line is usual topical treatment, topical steroid and non-steroidal, usually Nevanac. After first 6 weeks, we check again. If the CMO is not improved, usually we prefer to go with the DEXA implant. However, in patients that cannot have a DEXA implant for contraindication, or in the patient that we have that have basically inadequate response to the DEXA, we are starting using this topical Durezol, which is the fulprednate FDA approval. And I just wanted to show this beautiful case, 72-year-old male, complicated cataract surgery, PC rupture, unstable zonal, systemic contraindication to oral steroid. This is our patient after 12 weeks of topical steroid and non-steroidal, so still very active. We couldn't put a DEXA implant, so we decided to go with Durezol, and this is our patient 8 weeks after on Durezol, beautiful resolution of the CMO. So to conclude, local versus systemic, of course, is a balanced decision. You need to take into account diagnosis, type of uveitis, the severity of uveitis, location of inflammation, presence of absence of systemic inflammation, and also patient general health and comorbidities. Just remember that a combined approach, local and systemic, may result in better inflammatory control with less side effect for your patient. Thank you for your attention.
Thank you very much for this very, very clear, very guided presentation on a topic which was interesting for all of us, specialists in uveitis, just retinal specialists as well. I think you very clearly put your views about the options of systemic, local, and combination of therapy. And I think the strategies will certainly vary. People may have different preferences, certainly because we have the same experience in terms of what we do. But I think it's important probably for you to say in terms of the Ozurdex and jumping to Iluvien after that, how do you plan that transition, from Ozurdex to Iluvien? How do you plan that?
So we usually go with Ozurdex first, and then we wait and see what happened after the 3-4 months once the Ozurdex expired. If we have a recurrence of the CMO, then we tend to put another DEXA implant because, of course, is a license for active disease. And then after 4-6 weeks, we usually put an Iluvien. Yeah. So in this way, after the effect of the Ozurdex is over, we basically prevent the recurrence of the CMO with the Iluvien, that it will be already up and working in the vitreous.
Thank you. Just one final comment, which is just for people to remember. The other reasons for sometimes edema that you can see at the OCT image, so the edema is a bit odd shaped and all that, it'd be mechanical forces on the retina, so epiretinal membrane or vitreomacular traction, which are important things to differentiate, because then your medical strategies may not work for the reason there is something mechanical inducing the accumulation of fluid. So just a final comment on that. Thank you very much again. Beautiful presentation. I'd like to introduce now Professor Sofia Androudi from Greece, who will cover this very important topic of inflammatory choroidal vascularization, which is a common, or not a common, but an important complication of any of the conditions we've heard about. So Sofia, thank you very much.
Thank you, Bahram and Carlos, for this kind invitation. And we're going to look at the ocular neovascularization in uveitis, and this entails the choroidal neovascularization, the retinal neovascularization with new vessel on disc or retinal new vessels, and the rubeosis aridis. And for the sake of this presentation, we are going to talk about choroidal neovascularization. Uveitis choroidal neovascularization is a rare, sight-threatening complication of posterior uveitis, which is favored by low-grade chronic inflammation, chororetinal scars, and choroidal granulomas. It has some distinct features compared to neovascular AMD, which is a type 2 choroidal neovascularization, mostly younger patient with a chronic inflammatory background. How common it is? In the side cohort study, in about 15,000 eyes, the prevalence of choroidal neovascularization was low in anterior uveitis and intermediate uveitis, and it was higher in posterior uveitis, about 2.7%. And again, also, among at the 2-year follow-up analysis of 4,000 eyes with posterior or panuveitis and free of CMV at the time of cohort entry, the cumulative 2-year incidence of CME was around 2.9%, and this was favored by active inflammation, a pre-retinal neovascularization, or a prior diagnosis of CMV in the contralateral eye. And the incidence was higher in VKH, PIC, and multifocal choroiditis and serpiginous. And it's worth to mention that at bone diagnosis, 22.7% of patients with multifocal choroiditis and 76.9% of patients with PIC will have already choroidal neovascularization. This is a case of a young female patient with a span of 10 years after the diagnosis, and you can appreciate how the choroidal neovascularization enlarged, and also the lesions next to the optic nerve also coalesce, despite the treatment with steroids, anti-VEGF, and photodynamic therapy. And this is another case of a multifocal choroiditis, first diagnosed in 2006. And you see how the eye progressed only 2 years later. And this is how both eyes progressed over 6 years. And this is the pictures from 2006, and 6 years later, you see the evolution in both eyes over 6 years. It's very important for this patient, the fluorescein angiography. This patient will have hypofluorescent spots in the peripapillary region, and this may leak, and they might look, because the patients are young, you might think that you have to deal with central serous chororetinopathy, but of course the OCT and sometimes the ICG can clinch the diagnosis in difficult cases to diagnose. This is another case of multifocal choroiditis. He was 15 years old when he was diagnosed. He received anti-VEGF injection with good result. And you see how the lesions, the peripapillary lesion, progressed over the years. And this is her most recent follow-up. And you can see the neovascularization at the OCT. The OCT cannot give you a clue if this is active or inactive, and you also have to assess with multimodal imaging. This is another case of acquired toxoplasmosis that was treated previously with steroid and developed chororetinal neovascularization. And this is the most recent follow-up after treatment with steroids, with antitoxo drug and anti-VEGFs, and you see a big chororetinal scar. So correct diagnosis is always important. This is another case of a patient with syphilis that was hospitalized in a mental institution. The follow-up showed that this patient was positive for syphilis. The treating doctors were unaware. You can appreciate the hypofluorescent spot and the neovascularization next to the macula. This is another case, rare case of subretinal fibrosis and uveitis. And this is the autofluorescence, and this is the fluorescein angiography, and you can appreciate the severe inflammation, neovascularization, and fibrosis. And of course, this patient has a very bad prognosis, and you can see also at the OCT the neovascularization. This is another case of VKH, both eyes. You can appreciate the severe fibrosis secondary to neovascularization in the left eye. And this is another case of sympathetic ophthalmia and the neovascularization next to the macula in the only good right eye. So what are the pairs of diagnosis of inflammatory choroidal neovascularization? At first, you need to differentiate, to make a differential diagnosis between inflammation and choroidal neovascularization. For example, in OCT, you need to know what if you see an inflammatory spot versus a true choroidal neovascularization. And what the literature says, that OCTA allows correct diagnosis of choroidal neovascularization in 40% of cases where multimodal imaging could not pick up a correct diagnosis. And of course, OCTA alone cannot distinguish between active and inactive inflammatory lesion, and this should be integrated on a multimodal imaging approach. And what is the natural history of these lesions of the choroidal neovascularization? After 3 to 5 years, the literature says to us that it has poor outcomes with vision ending in less than 20/200 in 38% of patients, up to 77% of patients. And can this prevent it? Yes, it can, because CNV at these cases at least partially is driven by inflammation. And the literature says that around 2/3 of patients on IMD did not have new or recurrent CNV in a cohort study of 59 eyes. It also, the literature says to us that oral steroids plus minus cyclosporine or other IMD, we had a resolution of CNV in 13 out of 17 eyes. And in the Wilmer cohort study, approximately on patients with multifocal choroiditis, approximately 83% had a reduced visual loss from CNV with immunomodulatory treatments. So uveitis, choroidal neovascularization, you need to control the inflammation to inhibit the neovascular proliferation. And the inflammation control is mandatory with systemic corticosteroids, immunomodulation, and local steroids, and the treatment of CFV with anti-VEGF and or photodynamic therapy. Some prayers for treatment, you need to steroid, never forget the steroids plus minus IMT, even if no apparent active uveitis. And of course, don't forget the role of VEGF in uveitic CNV, because we know the aqueous VEGF is high in uveitis, is higher in uveitic CME, and it's even highest in uveitis neovascularization. So some clinical pairs on uveitic CMV. There is evidence in the literature, level 3 evidence data. You need to always control underlying inflammatory disease. You need to treat the complication of inflammatory disease, the CMV, with anti-VEGF. These are type 2 choroidal neovascularization in young patients. And you don't always do an induction phase as you do when you treat AMD. And there is overall treatment burden less than that compared to that of AMD. But again, you need to control the underlying inflammation. So how common inflammatory choroidal neovascularization, how common it is and in which cases? It's uncommon, mostly in posterior uveitis. Can it be prevented? Yes, with control of inflammation, but of course there is disease-specific effect. For example, multifocal choroiditis is more aggressive. Any prayers for treatment? Yes, anti-VEGF, PRN with control of inflammation. And prayers for diagnosis, OCTA to detect CMV with a correct slabs, but not to evaluate CMV activity. And thank you for your attention.
Thank you, Sofia. And yeah, this is a very challenging situation many times, because we seem to be controlling the situation well, making sure we preserve the vision, and the membrane will come up and change the game completely. I think you made a very clear point, which is important to control the inflammation, because that's what's driving the appearance of the membrane. And if we just address the membrane with anti-VEGF, we miss the opportunity of really controlling these and preventing recurrences. So I think it's a very important point that you made. Do you normally use your anti-inflammatory alongside? So you give your anti-VEGF, you give them oral steroids, you put an Ozurdex. How do you approach this situation when there is an active membrane and the inflammation is probably still active? How do you address that in your practice?
It depends on the case. For example, I saw some cases there here of multifocal choroiditis. The one was a young, I think 15-year-old female that had her anti-VEGF injections, but you see how the peripapillary lesion progressed. So I was hesitant to give her immunomodulatory treatment, and I expect her to relapse as she grows older, but you don't know. The other case of multifocal choroiditis in both eyes, she had psoriasis also, so she was treated with biologics. So it depends on the case. It's a case by I would say it's a case by case. I would go case by case.
Okay. Bahram,
but I know they need. I try to persuade them, but sometimes they are very hesitant. I mean, not a lot of people want to be on IMT treatment, but if they understand that and they understand how severe it is, they go for it. But you cannot always persuade them to jump into an IMT treatment.
Yeah,
Carlos, I think we had some questions actually on the Q&A, and there is one because they were answers by Ilaria and Elisabetta, but there is one for Zohar. Zohar, excellent presentation. Any opinions on chronic Lyme-related posterior uveitis? Would you say it's immune-mediated in the chronic phase?
Yes, it may be immune-mediated.
9 p.m. question, huh?
Yeah, yes, for sure. I think that it may be immune-mediated in the chronic phase. And as we all know that Lyme disease is actually being treated by us as infectious disease in the acute phase. But for the long run, we know that we may, see chronic findings, but then we give the patients corticosteroids with no addition antibiotics for the long run.
Thank you. And there is a last question for you, Sofia. Usually to differentiate CNV or inflammation, we can inject anti-VEGF and see whether the lesion decreases in size, since OCTA cannot exclude inflammation. So what would be your approach?
I would already answer that, Bahram, and said I would go for a multimodal imaging approach also with NFA before injecting.
Okay. Thank you, Carlos.
Bahram,
back to you for the concluding
one
remarks.
final comment here on the questions here before we close. Just on the unilateral VKH question to Elisabetta. I always think if you have doubts, you do an ICG because there could be asymmetry in the presentation. So what looks like a unilateral VKH is actually already present in the other eye, but not manifesting itself as a serious detachment. So the ICG will identify the early manifestations of that. So it's something you have to remember to do.
You are absolutely right, as unilateral VKH doesn't exist at least in the diagnostic criteria. So, and Elisabetta replied as well that you need to exclude the posterior scleritis.
Posterior scleritis, Okay, I think we got to our limit here, Bahram. I think we covered this very well. I'd like to thank you all the speakers, for really, really instructive presentations. I think this is, I hope our colleagues, retinal colleagues who are participating in this are benefited from this very targeted kind of presentations on topics which are relevant to all of us. And you can also, the sessions have been recorded, so you can be accessible again in case you need to review what was said, discussions and all that. So I want to thank you all. Thank you, my co-chair, Professor Bodaghi. Thank the speakers. Thank you, Retina, for putting this together and organizing the session tonight. And thank you for the audience to staying with us until now, and enjoy the rest of your evening. So I'll bid you all farewell. Okay.
Happy holiday season. Bye-bye.
Exactly. Happy holidays. Take care. Bye, everyone.
Bye-bye. Bye.